Good evening, everyone. It's a pleasure to be here tonight for the European Knee Society hot topic. And tonight we're going to focus on an exciting, topic, which is the anterior, knee space. And we have the privilege to have Professor David Barrett with us tonight. He's not only the former, president of European Knee Society and a great surgeon, but he's also the world expert of the anterior space of the knee. So we're going to be really delighted to have a lecture from David for the next 20-25 minutes. And then we're going to have Charles Rivière from Bordeaux and Michel Bonin from Lyon. We're going to challenge David with burning question. We're going to also need questions from you guys using the chat. And it's going to be an intense 40 minutes of discussion with David. But first, David, the floor is yours for your lecture.
Thank you. It's a great pleasure to join you guys, and I'm looking forward to discussions. I'll just bring up my my presentation, and there we go. Okay, all right. So I'll talk for a little while, and let's see what happens. And so this is what we want to talk about: is the third or anterior space in the knee. It is indeed a hot topic. It's new, and it's a very much an evolving speciality. And the way we explain this is it's the third space. We know the first and the second spaces. That's the flexion and extension gaps. So we're going to talk about the third space, the patellofemoral joint. Now, it's not the patellofemoral joint alone. It's the patellofemoral joint, the extensor hood apparatus, the quads, and the medial and lateral retinaculum and patella tendon. And so this third space, we want to balance it the same way as we balance the flexion and extension spaces. That is the first and second spaces. The important thing about the third space is it's highly innervated soft tissue. It has a highly variable movement. We probably don't understand very much about it right now, but it's highly demanding for both the patient and the surgeon. And so this is the background, if you like. We know that 1 in 5 of our patients are unhappy with their total knees. And of those people that are unhappy with their total knees, almost half of them, it's because of anterior knee pain. And just to remind those that might be listening to this webcast, this is not about whether or not we resurface the patella. It is really about the whole third space. It doesn't really matter if the patella is resurfaced or left native. So this is a lecture for people who both resurface or do not resurface the patella tendon. And the reason we know it's not just about, the patella bone. The reason we know it's not just about whether we resurface the patella or not is because anterior knee pain is the same whether or not we leave the patella native or whether we resurface it in total knee surgery. And what's more, even if we have a painful native patella in a total knee, secondary patella resurfacing does not really get rid of anterior knee pain. So it's about the whole highly innervated extensor hood. It's about its tracking and tension and balance. And what's more, anterior knee pain is a function of tibiofemoral stability. We know that if you have an unstable tibiofemoral joint, as the femur slides forward, it would increase the patellofemoral pressure or the pressure in the extensor hood. So it's really all about knee surgery and how it presents with pain. And this is why this is important, because in instability, of course, the femur slides forward. That's going to increase the pressure on the extensor hood, giving anterior knee pain. So it's so not about whether we resurface the patella or not. It's about the whole joint kinematics. And so patellofemoral kinematics is a difficult thing. We don't really know very much about it. It's very difficult to measure on x-rays. And so the only way being able to do this is by actually building a dynamic FEA model, a computer model of what happens in this changing viscoelastic structure that is the third space. So what we've done is instrument a cadaveric knee, which allows us to record the pressures in the patellofemoral joint, and then use that to build a computer model of the patellofemoral joint. So we can see how the dynamic movements change the pressures inside the hood. And so when we look at what happens, you can see this is how the patellofemoral joint works with the soft tissues. And this is why it's not just about the patella, because you'll see the patella drops out of the trochlear relatively quickly, and it's the extensor hood that wraps around the trochlea in higher flexion. The extensor hood is highly innervated, so it's very sensitive. And so this is why the design of the trochlea, or the interaction between the soft tissues and the trochlea of our total knee replacements, is so important. Because actually, the patellar contact forces aren't terribly high. As I show you these videos, anything that is blue and green is physiological pressure. Anything that's red or orange is supra-physiological, that is unpleasant and painful. So you can see the patella isn't particularly loaded, whether it's resurfaced or whether it's left native. And why this has become a bit more of a problem recently is because we've got better at knee surgery. So 20 years ago, when it was acceptable just to have 90 degrees of bend in a total knee, you can see most of the force on the extensor hood went through either the fairly insensitive patella bone or the polyethylene, which has no nerve supply at all. When we go to a higher demand knee, where we get better flexion, you can see how important the design of the anterior third of the knee is, because it's the soft tissue that wraps around the trochlea. And that resultant force goes right in to the soft tissue, much as our video showed earlier from our computer model. And here it is, the predictive model saying where will the stresses occur as we go to deeper flexion. You see, they're certainly not, the red color is not in the patella, it's actually in the quadriceps tendon, as the quadriceps tendon wraps around the trochlea. So you can see that's where the red area is, that's where the patients get their pain, and that's why anterior knee pain is significant. So we need to understand a little bit about patellofemoral mechanics and the changing character of the knee. And the key angle is about 30 degrees of flexion. So before 30 degrees of flexion, 0 to 30, the movement of the patella is fairly variable on the surface. And so the flat area of the trochlea means the patella is fairly unrestrained and has a variable movement. And the retinacular fibers guide the patella until about 30 degrees, when the patella commits to the groove and becomes anatomically stable, so much more constrained. So it goes from unconstrained to constrained, lightly loaded to heavily loaded. So the retinacular fibers have to guide it from wherever it starts from and guide it into place. So the trochlea is really acting as a funnel. So the patella will come from many different directions at the start of knee flexion, but then end up being guided down the intercondylar notch. So this is the problem we often find in knee surgery. We have a lateral tightening patella, which fails to commit to the trochlea. And so we can't really leave it like that, okay? And so classical teaching has us saying, well, we must change the patella. We'll orientate knee along the epicondylar line. And therefore, in order to get that patella in the correct place, we will have to do, we've already done a medial approach, but we'll do a lateral release. And so you can see we've actually released both retinacular fibers. And so how important that they were for in the first 30 degrees of flexion, we've actually created patella instability because there are now no longer retinacular fibers to guide the patella across the flat surface of the trochlea and deliver it to the groove. Now, as a result, knee designers a few years ago were making much deeper trochleas to try and constrain or capture the patella because they realized the patella was unstable and we were seeing high rates of patella dislocation. So the design of knees a little while ago had deep trochlear designs, which was constraint in early flexion, which was exactly opposite to what we wanted. So now we understand the trochlear function, we can make something that has low constraint early and much higher constraint later on. So it's just like nature. So the idea, it just matches the soft tissues when the patella wants to move. We've also redesigned our implants. And so in yellow is an older implant, and you can see it has relatively high trochlear shoulders. By reducing those trochlear shoulders, by opening up the groove, we can make this much more physiological, and there's less pressure on the patella and the soft tissues of the extensor hood. Now, coming on to how we do this. For those of us who resect the patella, many of us will measure the patellar resection because we want to replace the amount of bone we take away by exactly the same amount of polyethylene that we will put. So it's the same that we might measure a distal resection of a femur or the posterior section of the condyles to make sure we've taken enough bone to replace with metal or plastic. However, how many of us do this? This is the trochlear resection. How many of us measure the trochlear resection? Now, remember, the trochlear resection is important to people who either do or do not resurface the patella. It's the same for every knee surgery. And so I'm measuring my trochlear resection in this picture on the right, and it's about 10 millimeters of bone. So if I look at my knee replacement, my trochlear is about 6 millimeters thick on my knee replacement. So I'm taking my 10 millimeters of bone and replacing them by 6 millimeters of metal. So I have under replaced that by 4 millimeters. Sometimes I'll take just 2 millimeters of bone and replace that by 6 millimeters of metal. So I've overstuffed the patellofemoral joint. So understuffing, overstuffing. And the question is, would we accept 4 millimeters of mismatch if we were balancing our first and second gaps, that is, our flexion and extension gaps? And the answer is, we probably wouldn't. So why would we accept that in the third gap or the anterior gap of the knee? And actually, it does make a difference. If we can say that green is the perfect trochlear resection, where 6 millimeters of bone are replaced by 6 millimeters of metal, what happens if we overstuff that? And you can see in blue, that's an overstuffed or a larger than it should be trochlear. And so the effect of overstuffing that third space is there are 7 millimeters further quads travel, which increases quads pressure by almost twice. So these are the people that say they have a tight band across the front of their knee, that they always feel tight and they can't bend it. Their x-ray look fine, but their soft tissue tension is too much across the third space. Let's say we understuff it in red. That is, we don't put enough metal there. What's the effect of understuffing it? It produces quads laxity. So you have to work 2.3 times harder to get the same extension because you've lost the lever arm of the trochlear, the offset. And so these people feel, they tell you they're tired after they've walked up a set of stairs because they really have worked twice as hard to walk the same stairs. So that means that what we're asking you to do, as well as thinking about your flexion gap, is you've got to think about your trochlear resection. And ideally, we'd like you to take as much trochlear as you're going to replace with metal on your implant. So ideally, the trochlear resection should be the same as a trochlear thickness of the total knee replacement. So that means that we have to fine tune our femoral position. And that means taking a posterior up approach to the knee. And so when it's an appropriate resection, that's absolutely fine. Let's say our next case is a bit bigger. So if we put the same size 5 femoral jig on, you can see our resection at the top here will be more. Let's say it's now 10 millimeters. So what we will do is we'll change our size 5 to a size 6. Because we're using posterior up, the flexion gap will be the same, but we will grow the implant 3 millimeters higher here. So that means instead of taking 10, we'll take 7, which is appropriately very close to 6. But we'll take a 6 narrow because we don't want to grow the implant too much medial-laterally. And one of the little tricks you can use, because there isn't a proper instrument for this, is use the tibial stylus to guess how much you're taking away. And so here I'm using the tibial stylus in the anterior cut, so I can see that I'm probably going to remove too much tibia at 10 millimeters, and I want to change the femoral gap. So what we try to say is that the third space is all about the position and sizing of the femur, and it's probably been neglected up to now. And what we need to do is understand that we can change that with our femoral positioning, and we don't have to alter our flexion gap if we use a posterior up approach. So that's the important thing, is now thinking about our trochlear resection and making sure that is correct in the next knee replacement that we do. So there is another thing that we need to do better, and that's femoral orientation. So, and this comes into very much into Michel's interest in custom-built knees, and also Charles's interest in alignment. This is our standard alignment from the 1970s, and this is what we were working on, mechanical or anatomical axis. 1970, this picture was taken. And this has led to perhaps a perception that the reason we rotate the femur because it aids patellar tracking. In fact, as you know, because we're limited in mechanical extension, mechanical alignment, we can't make a cut like this. We have to make a cut that's allowing us to have a rectangular flexion gap. And so that means we will externally rotate the anterior cut as well. So really, it's not anything to do with patellofemoral tracking. It's actually a compromise that is forced on us by total knee surgery. And it's not a requirement for the patella at all. Unfortunately, we're still doing the same with drawing lines on x-rays 50 years on. Now, there are many different lines we can draw, but this is all largely about axial alignment. What effect does that have, and why has this become suddenly important? So this is, of course, Johan Bellerman's paper, where he found out that actually most of us are at 3 degrees of varus anyway, the concept of constitutional varus. And initially, all of us were very worried because in 1984, it was shown that as soon as we went away from neutral mechanical alignment into valgus and varus, we had higher rates of failure. And so 20 years ago, this is a paper from 2003, we were focused on navigating our knees to make sure 100% of them were at 0 degrees plus or minus 3 degrees. And that, we thought at that time, was the secret to success. If only we could get every knee at 0 degrees, everything would be fine. So that's what we were looking for. Now, obviously now we know, and we were prepared to accept plus or minus 3 degrees. Now we know that probably we might be going minus 3 into 3 degrees of varus. When we add plus or minus 3 degrees error, of course, now we move out to a possibility of minus 6. And so now we've got an knee implanted 20 years later, which is so far off the scale, it's hardly on this map. So it is a different alignment. And so what do these altered femoral alignments have? What effect do they have on the third space? Let's say our Q angle in this knee design is 3 degrees. So remember that every single knee on the market now has been designed for mechanical alignment, 0 degrees. So there's no knee that has been designed for kinematic alignment or constitutional alignment. So let's take this tibia. Now, let's say they put it in at 6 degrees of varus, restricted kinematic. And so instead of 3 degrees, if that's 0, the resulting Q angle is minus 3 degrees, 3 degrees on the wrong side. Okay, so effectively what we wanted was plus 3 degrees. So there is 6 degrees of patellar maltracking in this knee. And that's very significant malalignment from the original design, which was supposed to be plus 3. We've gone right over 6 degrees to minus 3. There is some data, and Seb Lustig has published this, suggesting that if we look at some of the computational analysis, that might have an issue with patella tracking. And there are a high proportion of patella complications in the knees in the Australian registry. So just some early cautions there about the patellofemoral function in some different forms of alignment. And now, perhaps the most important thing is, would these knees perform well outside the design envelope? Because it takes so long to design a knee, there are no new knees released that are designed for the new alignments. They're all designed for 0 degrees plus or minus 3 degrees. And so we can look at a probabilistic analysis and say, what happens if we malalign these knees? How does it affect the function of the implant? And what are the probabilities that they will perform? So here is a CR knee. And you can see on the left, we have it performing well at 0 degrees. So by bicondylar contact, good kinematics. If we put it in at minus 6 degrees, so 6 degrees of varus, you can see exactly what happens according to the computer, that it will start lifting off on the lateral side. And you can just see it step out there of the lateral side. What does that do? You can see it now has quite a significant effect on the loading of the polyethylene, which is now supraphysiological or red. So this knee is now not performing as it was designed when it's put in at minus 6. If we take a medial pivot knee, a different design of knee, okay, at 0 degrees, it's functioning well, medial side this side, lateral side this side. If we put it in at minus 6 degrees and run the analysis again, stays put on the medial side, but you can see it lifts off very significantly now on the lateral side. And the effect that has on polyethylene loading, you can see there a great big patch of red where pretty much it's unicondylar loading. So each implant will react differently, and it's worth checking if that implant will tolerate -6 degrees. And you can see that, so for instance, a design like this wouldn't tolerate -6 very well. Design like this probably would. But most of the companies don't know because they don't have the ability to run this kinematic analysis. And then finally, what I'd like to come up is can we be a little more accurate than trying to measure error sections? How do we do this dynamically? And I've spoken about this a little bit before on Hot Topics. And so we published our data now with my co-worker, Angela Brivio, and the team at QuadSense about how we are going to measure the patellofemoral pressures. And the idea here is that we change the order of how we do the knee surgery. The patella resection comes first, and a small sensor goes on the back of the patella. We then bend and flex the knee 5 times and record the pressure profiles in 4 different quadrants in the patellofemoral joint. So this is what the native knee is like. And we end up with a very consistent pattern that's reproducible over 5 flexions, which shows us that there are a definite repeatable pattern of pressures in the knee. What we then do is go ahead and do the knee replacement. Okay, so the femur is in there, and then we repeat the analysis to see what effect putting the total knee in has made to patellofemoral pressures. So we compare that with the natural. And what we find is it's not only is it repeatable and recognizable, but it's radically different to what we had in the native knee. Every single case we've looked at. So you can see this is almost understuffed because the pressures aren't high enough and they're in a different relation. So it would be great if we could get it back to where it was before they came to theatre. So we now have a series of shims that we can put on the back of the patella. So by altering the depth and angle of the cut, we might reproduce the level of pressure and the pressure patterns that were in the knee before we put a total knee in it. So hopefully a little more native. So that's a natural one here. This is what happened afterwards, and you can see the radical difference. And by putting different shims in, we can make different patterns in the knee. And that's obviously not what we want. That's the wrong way round because the blue is too high. This is getting close, but the relationship between the yellow and the blue is not so good. And this is probably our best match for what we've got, cutting the patella with a little superior wedge. So we can reproduce that and see if that makes a difference to the anatomy of the knee and how it functions. All of this has just been written up by myself and Angela in the Effort Open reviews. If you're interested, it's in a little more detail, obviously. So what I wanted to say at the end of this was that hopefully we've alerted you to the anterior space, or the third space in the knee. It's important, and we can show with dynamic patellofemoral monitoring that there is consistent and reproducible pressure patterns, and those patterns are very individual. And they're certainly very much changed as soon as we put a total knee in. We can do things with our knee surgery right now to change the femoral positioning, which makes sure a trochlear resection is much more accurate. And I think that will help a lot with patellofemoral pressure. And it's just a discussion point, really, is will some of the new alignment techniques have an unexpected effect on some of the patellofemoral tracking and what we might expect from patellofemoral performance. Thanks very much for listening.
Thank you very much, David. Now, Michel, Charles, floor is yours to challenge, David with burning question. I'm sure you have tons. And also for the ones who are listening to us, you can use the chat for, and ask questions to David. I will do the follow-up. Charles, Michel.
Thank you, David, for this excellent presentation. And what I understand from your talk is, first, that one of the main difficulties that we have with the patellofemoral joint is the reproduction of the native alignment and the native anatomy. And second, because the patellofemoral joint in a TKA is trapped, is the slave of the tibiofemoral joint. So your presentation, in fact, is an advocacy of 3D planning, 3D navigation, and custom implant. What do you think of that?
I can't imagine how you came to that conclusion, Michel. I don't know why you would say that. Okay, so no, and you're absolutely right. And that's why I said halfway through my presentation, this is why it's quite interesting from Michel's point about a customized knee. because one of the things we know is anatomically, the trochlear and the development of the tibiofemoral joints are not linked. Okay, there is nothing, there is no landmark in the knee, epicondylar axis, posterior condyles, Whiteside's line. There is nothing that links the trochlear, the orientation of the trochlear, with the patellofemoral axis. The tibiofemoral axis. And so I think you're absolutely right. The design of the trochlear is often added afterwards in knee designs, and it's orientated in the same way every time. What we know is it's very different individually. And so this would be a good way to say, well, perhaps I should orientate my trochlear like it is in the natural knee. And you would have that ability with a custom knee.
Yeah. And this is also a question for Charles. Charles, you are on mute. Huh? Because in your presentation, David, you said that all the current TKAs are not designed for key A. But I think that the only implants which are really designed for key A, in fact, are custom implants. So what says the specialist of the key A, Charles?
Can you repeat, please? Because I tried to reactivate my sound.
Sorry. In his talk, David was saying that all the implants currently available have not been designed to fit with key A and with the variability of the human anatomy. And I was saying that, in fact, the only implant really designed for key A are the custom implants.
So, of course, I disagree. I find the custom implant an attractive solution. You know that, Michel. But the evidence is showing that kinematic alignment with generic implant design on the market is working pretty well. So the complication rate with the anterior space is very low and almost negligible. I've been performing kinematic alignment for 10 years, routinely, unrestricted. I had one patella dislocation, and I'm using generic implants. So I disagree with this. I think implant that have been designed for MA works pretty well with KA. We can probably do better with a new implant design, more, with some, improvement on the trochlear design, that better fit a K philosophy. But I think current implant already works amazingly well. Because I think so at least the implant I am using, the trochlear design is quite forgiving. The sulcus is wide and it catch pretty much, the whole patella. And I do measure my anterior cut, my trochlear resections, making sure that I am not overstuffing, the native trochlea. So my answer is, I think current implant design works pretty well for MA and also for KA, but new implant design, even generic, may do even better for KA.
So actually, so Charles, there's two questions. I can see one of the questions in the chat, which might be relevant now, is a question for you, Michel, talking about, you talked about the customized implant. You say, okay, we can make it to like the trochlear, but what alignment would you use? Do you customize the alignment as well, or do you just do 0 degrees and design the knee around that?
Yes, with custom implant, we reproduce the native tibiofemoral alignment in a certain limit, but we reproduce the native alignment. But the magic of the customization is that it allows decoupling of the tibiofemoral alignment and the patellofemoral alignment. So by this technology, the patellofemoral joint is not anymore the slave of the tibiofemoral joint.
Sure, no, I think that's absolutely right. But at some point you must decide what angle you're going to cut the tibia. So do you do like Charles and you take maybe a varus tibial cut if the patient's varus, or do you say we're going to take a 90-degree cut and then we build their implant off that?
Yes, in the custom that we use, we have defined boundaries and we cut tibia and femur at ±3 degrees of inclination compared to the mechanical axis, and the obliquity of the implant itself is ±2 degrees. So as a result, we can have an inclination of ±5 degrees from 90 degrees in the tibiofemoral implant. and the orientation of the trochlear is independent with the tibiofemoral joint line, so it makes things much easier. And in fact, I remember that in this video, in this hot topics, you explain when you spoke about the patellofemoral joint prosthesis, that you progress in that implant because you understood that you should abandon the rules of TKA for the patellofemoral joint prosthesis, and this makes you progressing. And it's very interesting because we are converging with the same ideas.
Oh, that's true. That's true.
David, I have a question for you. You showed us some threshold, 4 millimeter.
Yeah.
We should not overstuff or understuff more than 4 millimeter. But if we have, let's say, a very thin patella, we're going to increase the thickness of the patella with resurfacing, because the minimum thickness of the poly will be 7 or 8 something. So how do you consider, the anterior space regarding both, femur trochlea and patella resurfacing? Where should we play? I mean, if we have to increase the thickness of the patella, would you go to understuff on the femur, or is it too complex?
No. So nothing can be too complex for a knee surgeon. We're quite capable of making something really, really complex, so no one can understand it. So, but the way this usually happens is the way it usually happens is you make your trochlear resection, and you will say, I'm not plus or minus 4, but I'm plus or minus 2. Let's say I'd like to take 6, but I've taken 8. And so if you're a patella resurfacer, what you can do is say, when I resurface the patella, instead of taking 9 millimeters for a 9 millimeter poly, you take 7. And so you actually make that 2 millimeters up in the patella resection.
But David, when you perform a mechanically aligned total knee, you tend to overstuff distally the lateral condyle, femoral condyle. So if then, because you did understuff your trochlea, if now you undercut your patella, then it's going to add even more tension on the lateral retinaculum when the knee is bended, which may cause anterior knee pain. What's your opinion on that?
So I agree. So I agree about that. Mechanical alignment tends to overstuff because that lateral femoral condyle is coming up here and actually is unphysiological further forward. So I agree with that. But if you were, let's say, if you take a 3-degree varus cut, which is not unreasonable for constitutional alignment or whatever, if you're taking your femoral cut off that tibial cut, doesn't it have the effect of internally rotating the femoral prosthesis as well? Because you'll get a rectangular gap, but you'll have to internally rotate your femur, and that also sort of brings up the trochlear, the shoulder.
Yeah. A question, David.
So did we just move on from that without answering that question, Charles? Did we just? I'm sure I got an answer from that. Because how do you choose your rotation in kinematic alignment? If you cut off the tibia, so if that's 90 degrees and my tibia is a little bit.
Yeah. So I'm going to answer you. So as you said many times, ideally when we reconstruct a knee, we would like to restore native joint pressure, and so the belief, and I think it has been measured for kinematic alignment surgeon, is that restoring the anatomy, the native anatomy, will restore a close to physiological knee laxity and kinematics, which means kinetics and kinematics, so biomechanics. So that's why as a KS surgeon, we respect the native orientation of the joint line in the frontal and sagittal plane. So I would always rotate my femur parallel to the posterior condylar line, keeping a medial compartment stable and the lateral compartment more lax. And the level of laxity will vary between patients because it's unique for every patient.
But then the risk is to overstuff the patellofemoral joint, like
no,
David said.
No, never, because I always measure, and I can tell you we do not. And we did when I at the MSK lab a lot of study and simulation, like in silico studies, And if you know, when you perform kinematic alignment and you do the anterior cut flush to the femoral cortex, you always understuff the trochlea. Big deal. Always. You know, it's like always, except obviously the most proximal part of the flange, because it is extra anatomical. You know, the prosthetic, the TK, the implant, they've got a flange, a prosthetic trochlea that is extended proximally. It's supraphysiological. It was for an early catch of the patella. So obviously, we always overstuff in the most proximal part of the prosthetic trochlea. It's normal, because the native trochlea always start more distally. But on the articular part, no, we do not. We do not. We do not, because so that's why for many years, 5 years now, when I size my femoral implant, I do not try to do my cut flush to the anterior cortex. I try to find landmarks that enable me to better restore the trochlea offset. So we did a study when we use as a landmark the top of the lateral facet. Doesn't work. If you do that, you overstuff always your trochlea. So now we did a study where we use the medial facet, the top of the medial facet, or the groove, and so we have better outcome. So yeah.
But Charles and David, I have a question. If you have a patient, for example, with a joint line tilted by 4 or 5 degrees with respect to the mechanical axis, if you align your off-the-shelf femoral implant to this joint line, it has consequence on the orientation of your trochlea. So how do you manage that in your daily practice?
That's a question to me. So first, Michel, the clinical evidence show that it's working very well, because I mean, we are, assessing our patients, and we provide evidence, but there is already available evidence. Anterior knee pain has almost disappeared with kinematic alignment, and dislocation is absolutely exceptional. So I would say performing like an anatomical restoration of the knee by doing kinematic alignment. I mean, when I'm talking about kinematic alignment, it's unrestricted. It's restricted as well if the deformity is too high. But anyway, doing a physiological arthroplasty, which is trying to restore the anatomy of the knee, which is unique for every individual. I mean, this has significantly reduced complication from the anterior compartment, I believe.
So
the maintenance is so low. The maintenance is so low. And you know what, David?
David.
So let's just that. But the thing is, what we're doing, what I can see what you want to do, but I'm just saying that there appears to be a kinematic conflict here, because, and this is what Michel was talking about with custom knees, is that we're going to use a monoblock, if you like, symmetrical implant. Both the condyles are the same size, and we're going to put that, and that was designed for 0 degrees, okay? And so I can understand you might say, well, look, guys, we've got a different joint line here. We've got a 3 degrees varus. We want to reproduce that. But in doing that, that makes you compromise another bit, because you can't externally rotate the femur to lower the lateral pressures anymore, because you won't have, even the cat agrees with me. Which is just
if you do not overstuff, if you do not generate a trochlea overstuffing, prosthetic overstuffing, you cannot generate overpressure.
No, but that's what we're concerned about, Charles, is that both Michel and I have said that the risk is that you follow the joint line with a symmetrical implant, then you will produce an internal rotation of the trochlea. And do you disagree with the diagram I showed, where as you tilt the knee inwards, as the femur follows the tibia, which I understand why you'd want to do that, but naturally you're taking the Q angle across the negative side, not positive.
David, we did compare in an in silico study MA and KS simulation, and we found that with KS simulation we more closely restore the native trochlea anatomy. It's more physiological. So I mean, so you alter more the anatomy, the trochlea anatomy, with the MA implantation. We've published it, And,
I think we
and
should.
it's an in silico study, so it's the method is very robust because it is in silico, so it's computational. So I mean, data cannot lie, but I don't know what you're saying.
But the nice thing with the model.
Yes, David. You mean you're going to have your hair, sparking? So look, you said that.
So, Michel, we need to stop him. Okay. So,
Michel, go ahead, Michel. You have a question.
How am I supposed to have my hair in spikes?
I was just saying
showed, and I agree, because this is the.
Michel, stop him. Just tell him he's wrong.
Go, Michel. Go for a question. Your side. Your turn.
No, the magic thing with the model presented by David, which is integrate the biomechanics, the muscular environment, and etc., and it provides very accurate information about the functioning of the knee and TKAs. And the fact are stubborn. If you tilt too much the orientation of the trochlear, it modifies the peak of force on the diagram, if I understood well the study designed by David. That's true.
Yeah. No, and that's exactly it, Michel. It's the forces are radically altered, even in a standard knee, just without changing. So that the striking thing was, and this is the thing that Angela and I did, was that you can see that they're nothing like the forces the patient came into hospital with. As soon as you put the knee on, it completely changes. And so, just a question to you about how you change the trochlear angulation in your custom knees. You follow the patient's anatomy, is that right? And you can put the trochlear anywhere you want.
Yeah.
Which
because
features,
the three compartments. Excuse me.
Which features? No, which features? You say I restored the trochlear, the native anatomy, and that's fascinating. Just need to. Yeah, which features? Is it the trochlear, the groove?
Because you must understand that the three compartments of the knee are designed independently. Do you hear me well? I have. Do you hear me well?
That's a Wi-Fi.
No.
There is an echo. You should reconnect, maybe, Michel.
Yeah, perhaps.
Michel's reconnecting. Seb, do you want to take a question? There's a question about stop.
Wow.
Yeah, we lost. Wow. It's okay. Charles, we lost Michel.
Can you hear me well?
I can hear you, Charles.
I might reconnect as well.
So in that case, I'm just going to say to you, we lost Charles.
David.
Greeting. I think the other drink. But there you are. Saw you drinking wine there, so we know that you're relaxed. Great. Have Michel.
Yeah, the sound gets crazy.
That's the thing. Okay. Well done.
So, David.
Yeah.
Maybe it's Javid.
Sorry, I missed that. I can hear you better still.
You should reconnect.
Oh, you can't hear me. Okay. Hello.
You have to quit.
Yeah. Okay.
Yeah, sound is better, Charles.
Yeah.
Michel as well.
Yep.
So, Seb, question for you.
No, sure, yeah. I was gonna just ask, wait for the answer to Michel. When you say you restored the native anatomy for the trochlea, which parameter do you restore? The groove, or the lateral and medial aspect of the trochlea? Orientation, because there's
Well,
a lot of parameters.
yes, everything, but the way the prosthesis is designed is completely different than what we're used to have, because the three compartments of the knee are designed separately: the lateral condyle, the medial condyle, and the trochlea. So you can completely disconnect the orientation of the tibiofemoral joint line, and then you can reorientate the trochlea groove, the contour of the trochlea. So the trochlea, for example, is much shorter than the trochlea that we see with off-the-shelf implant, which is obvious when you use it. And so we reproduce completely the native kinematic, both in the coronal plane and in the transverse plane.
Michel, with a shorter flange, are you concerned with patient with patella alta? Because the extended, proximal flange serve to do an early catch to the patella, and maybe of use for patella alta. What do you think about that?
Well, I think that it's quite infrequent in osteoarthritic knee to have a patella alta important at the level to modify that, the engagement of the patellofemoral joint. So it's really not a problem. No, the main difficulty that we could have could be in dysplastic trochlea, and in that case, of course, we have to correct and to restore a normal depth of the trochlea. This is the main issue.
So, but I think that's an interesting. It's the word that Charles used about to catch the patella, and in English we talk about capturing the patella, and that was the design thing 20 years ago when they said they had a series of patella subluxations, and they made the trochlea grooves deeper and deeper because they wanted to capture or catch the patella. And they thought once they could catch it, it would stay on the front of the knee and it would be perfect and everyone would be happy. But what we know is that produces unphysiological soft tissue forces. And the patella has to move medial laterally because the position of the foot as you walk changes. And so that means the patella will start on maybe the lateral side one step, maybe the medial side the other step. So we can't catch the patella. The patella has to be free at the beginning of the flexion. We only catch it when it comes to 30 or 40 degrees, when it goes into the intercondylar notch. And then it becomes very heavily loaded and it has to be stable. But to start off with, it's got to be like this.
So what I wanted to say, David, is that so the custom implant, the origin is it's a patient-specific trochlea. But what I have opted for is a forgiving trochlea. And when I say catch, it means the trochlea I'm using is like a big net catching everything. So I'm not talking about increasing the constraint. I'm talking about increasing the capture, the catch. It's a big funnel, it's like increasing the funnel effect of the trochlea. So It's like wherever lies your trochlea, your patella in extension, when you start to bend the knee, the patella falls into this prosthetic, new
So why did you change your implant if there was no problem?
You know what, Seb? I agree with you. One patella dislocation for, with the implant I'm using, which is a GMK sphere, and the patient was quite lax. So it's just, we believe we can do even better. But I agree with you. It's just, everyone says, oh, you're using implant design that have been designed for the MA. All right, good. Let's do something for K. We won't win much, but we may win a little bit. And I think today this is a game. It's much small win. But clearly K has made total knee replacement more reliable. The maintenance is clearly less. And so now we have to gain, small win. And small win is to do a forgiving trochlea that is capturing everything. To reduce the remaining point, I mean, 0.2% of patellar dislocation you may have.
David?
Yeah, so I think that it might be better to talk, instead of catching or capturing, maybe better to talk about providing the patella with a large landing space, so that it's not constrained. Because for people listening to this, I don't think we need to use words like entrapment or catching. The guys want to go back and look at their femoral implants now, and they're going to say, how big is my trochlear groove? Do I feel comfortable with that now? Do I want something that's a little bit bigger, a bigger landing space for the patella? And I think that we just have to remember that so it takes about 6 or 7 years to design a total knee, and it costs a lot. So right now we don't have anything coming out that's designed for possibly -6 degrees of alignment. So I think it may well be Charles is right, because anything is possible, frankly. And so it may not matter too much, but in his studies. But I think we are seeing that these implants are designed for ±3 degrees, and some of them are not so tolerant to -6 degrees. So we just have to be a little aware, I think, that's all.
David, so now I think we did talk for 40 minutes about alignment. Maybe now let's focus on implant design. What's your opinion? Which implant design, in your opinion, and the evidence is demonstrating, is the most patellar femoral friendly?
Well, so what we'll see is I showed a picture of a sort of deep groove where a circular patella was captured in a deep groove. And I think what we've seen with the more recent designs is that you see they've opened out the trochlear. So your comments about having a forgiving trochlear are very appropriate. And so we're looking for a sort of a congruence angle of about 140 degrees, which means that a native patella will sit just as well as a resurfaced patella. I think the only thing that we haven't done very well is look at for those of us who resurface a patella, look at the design of the patella resurfacing. So at the moment, most people are using a dome, which is entirely unphysiological. So we're spending all this time trying to get a tibiofemoral line right, and then we're worrying about the rotation, and then we're putting a half moon on the bottom of the patella. So Michel, in your custom-built design, do you design for the patella as well?
Yeah, the patella is asymmetric but not customized. So it's something that we need to work about that. Yeah.
So I think that and some of the studies on that are now really interesting, because a dome is just physiologically unstable. And that's why we used it all those years ago, because it didn't really matter where we put it. But now, as we understand it better, because the patella is not actually a dome, it's actually it's concave, sticks to the front in the sagittal alignment. So I think for those of us who resurface the patella, we also need to look at the design of plastic we put on, because some of our studies will show that you can change quads efficiency by 10% by just changing the design of the patella button. Now that's a big.
Honestly, I'm not convinced that it is the main point in patellofemoral compartment of TKA, because it's always what I say to students, and what is obvious when you see your modelization is that the main joint is the joint between the trochlear and the quad tendon, and this is a completely forgotten joint. In fact, it's really amazing to see how much how the pressure is on the quad tendon during flexion, and this is dependent only on the orientation of the trochlear and the positioning of the trochlear. And it reminds me what was saying a very famous French knee surgeon, Philippe Beaufils, who was saying always to residents, it is not the patella who goes to the trochlear, it is the trochlear who must go to the patella. What do you think of this?
I think that's really good. I think that's really good, and you're right, and it's really good as we come to a close to say that actually, guys, don't take away the message. This is about patella button design. That is the smallest bit. You're absolutely right. The patella is in the trochlear for like 30% of the flexion cycle. It's actually out of the trochlear groove 70% of the flexion cycle. So it's really that interaction between our trochlear flange and our extensor hood, which affects us whether we're knee surgeons who leave the patella native or we resurface it. And that won't make a difference at all. So I think that's the key thing.
David,
yeah,
you said
go
that
ahead.
AP stability of the knee was important, you know, to improve the performance of the patellofemoral joint. So would you recommend implant design with, you know, that provide this AP stability, like a ultra-congruent medial pivot?
Yeah,
or
so
bifurcate?
I think so. I think that what we become aware of is that, and you will have all seen cases like this, and I guess people listening to this will have heard cases like this, where someone comes in with anterior knee pain after a knee replacement, and the guy says, okay, your first surgeon did not resurface the patella, that's why you've got anterior knee pain, so I'm going to resurface the patella and everything will be fine. And in fact, what the patient had was tibiofemoral instability. And so the thing was sliding up and down like this. It was causing pressure to the extensor hood, and even resurfacing the patella doesn't make a difference. So I think you're absolutely right. Tibiofemoral stability is intrinsic in third space pain. And it may be appropriate. I know you're keen on a medial pivot knee, but if that provides the AP stability that we need, that is a certain certain advantage. And so for me, I use quite a conforming knee, and I know that not everyone agrees with that, and they prefer to have a lesser conformation. But of course, that means there'll be a higher rate of anterior slide, which may be significant in anterior knee pain. So I think in your knee design, you're looking for quite a lot of congruity now, rather than just flat on flat, as it were.
David, if we want to go back to your study about, you know, measuring the anterior space, if you want to give an advice for surgeons who are listening to us, if they are in between overstuffing or, you know, understuffing, you know, we say if you make a mistake, we should do a mistake in the right direction. Where should we go?
So it's really difficult. I think what we showed. So our computer modeling showed that we got significant differences in that example I showed you when we were 4 millimeters out. If it's 1 or 2 millimeters out, we don't really see much difference. So I wouldn't like guys to beat themselves up when they were like 2 millimeters out, because this quads is viscoelastic, we don't seem to see much pressure change in the extensor hood in our models. When we're 4 millimeters out, that probably is so 3 to 4 is probably not acceptable. If you like, 1 to 2 is probably okay. I think if you're 1 to 2 millimeters out in your example, because I resurfaced the patella, I have a chance to change that in my patella resection. Okay, for the guys that cannot change it because they don't resurface the patella, and let's say they're up to 4 millimeters and they have to choose whether they undersize or oversize, I guess it's safer to undersize. Then a lot of people would worry if they're posterior up about notching. And so there is a natural tendency to oversize because you're worried about notching. And I think we worry about notching too much.
And I think Charles will agree on that.
Yeah, I do.
David. So guys, we are. No, I'm sorry, Charles. We are just on time.
It's nice. It's good.
Okay, one last question. Let's go.
David, you were talking before about the patella moving from unconstrained to a constrained, you know, part of the femur. So what is the importance of the mediolateral femoral positioning? Because it will have an influence on the, you know, where the patella is constrained. Yeah. So what do you recommend for that?
Yeah, so no, I think it's actually really important. And a lot of us think of, we just try and choose the most broad implant to cover the bone. But actually what we should be trying to do is not worried about that. It doesn't really matter if we underhang by 2 millimeters. What we should be orientating our femur on is on the intercondylar notch, because that's where the patella is going to want to be. And so if that means you actually have to move your femur a little laterally or a little medially, I would be happy to do that. Rather like I'm happy to move it up and down, I'm also happy to move it back and forth, because I am the slave to the trochlear.
Now when we're going to introduce you, David, I'm going to introduce you like this. David, the slave of the trochlea.
No,
You know,
I am he. I am he.
David, the center of the notch does not always correspond to the distal the location of the distal groove.
Yeah, I think that's a good, provided you haven't got an osteophyte there that would lead you astray. If you're using a CR knee or a knee that has a notch, you position it on the top of the patient's own notch. I think that's probably the most reliable way of go.
Yeah,
because that's where the patella's going to end up.
And one little comment.
Final one, Charles.
So you show in your finite element analysis that if there is an overstuff of the flange, when you bend the knee, it generates like a very high pressure and constraint on the quadriceps tendon. So I perform kinematic alignment and I try to restore the trochlear offset. So almost all my patients, not all, but almost all my patients, when you look at the lateral X-ray post-op, there is a distance between the anterior cortex, femoral cortex, and the flange. Okay, and sometimes it may be huge. And I measure everything intra-op, so I make sure that I do not overstuff the native trochlea. Obviously, I overstuff more proximally because of the extended part of the flange. So then sometimes when you look at my X-ray, it's big, and you may wonder if it's not going to generate anterior knee pain. I mean, I would not do that if I had issue with my quadriceps. So it's not an overstuffing of the native trochlea, but it's an overstuffing of the more proximal part, which is the non-physiological part, and it has no impact so far. And we will measure because we already started. But seriously, I have been doing this for 5 years, and I continue because I am very glad with the outcome. And I would have stopped if I did notice increased anterior knee pain.
You try to do custom trochlea with off-the-shelf implants, so Michel will like this, I'm sure. Well, guys, thanks a lot. We had some minor issue with the sound at some point, but otherwise it was really great debate, discussion. David, you always, teach us so much about the anterior knee space, and you see it creates a lot of discussion then, so I think it was really perfect. So thank you. Thanks a lot, Charles and Michel, for all the questions and the live discussion. And, this is the last hot topic before summer break. And we're going to start again in September 4th with robotic total knee. So it's going to be another hot topic. I'm sure we're going to have other, other meeting before that. But otherwise, we invite you all guys to see you for the next hot topic after summer. Take care. Bye-bye.
Thank you.
Bye-bye. Bye. Thank you.
Thank you, David, Michel, and Seb. It was excellent.